So my paper is Accuracy and Radiological Outcomes of OAM Navigated Dorsolumbar Fracture Fixation in Highly Unstable Fractures. So let us first understand the biomechanics of the spine. This is the normal physiological range of motion of the spine. You can see lumbar segment is quite mobile compared to the dorsal counterpart. So this leads to the high area of stress. Here the shear stress and translational stress is very high. So this is very susceptible for fracture. That's why we see 80% of fractures occur in this area only. And the importance of the injury to the PLC cannot be overlooked because it is the deciding factor in almost all the classifications. It guides us about the surgical or conservative management. So pedicle screws are the workhorse for fracture fixation since 1960, but there is still up to 10% breach rate with freehand technique, as there are anatomical variations. This is the standard entry point of pedicles. So a lot of new techniques are coming to improve the accuracy. One of them is OAM. It is a cone-based CT machine which guides about the trajectory of our pedicle screw. It is based on geometric calibration of the subject in the space. So this is the basis of our study, that the relative distance of the subject, the pedicle from the reference frame, should be constant for a good accuracy. So this is the geometric calibration in X, Y, and Z axis. So this is the reference frame that we usually use. So these 4 pointers are the fixed constant that guides the OAM about the orientation of these pedicle screws. So what is the concern? Why this study? So in 3-column injuries, there is micromotion, macromotion at the fracture site. So if there is a motion while inserting the pedicle screw or the any manipulation or the reduction maneuver, the accuracy will be lost. You can see in this is a type, this is an unstable fracture. It involves all 3 columns. This also involves 3 columns. You can see the posterior column is also involved. This is A4 plus B2 type. So relative distance of this pedicle to the reference frame, if this is changed, then we lose the accuracy. So we did a study. We selected 74 patients, 87 fracture levels were fixed. There were 702 pedicle screws that were inserted under OAM navigation. We used AO classification for our reference. So inclusion criteria is all clinically unstable fractures and that classify the operative treatment under AO classification were included in the study. Exclusion criteria were all osteoporotic fractures that are inherently anterior column involvement, and the stable fractures, isolated A1, A2 and single end plate fractures were excluded from the study, and the patients deemed unfit for the surgery were excluded. So how did we measure the OAM accuracy? So we analyze the pedicle breach. We quantify the pedicle breach in all the fractures and compared our cohort. We compared the stable versus highly unstable fractures. Facet violation that leads to adjacent segment syndrome. If violated, we violate the cranial facet. We assess the local kyphosis correction and radiation dose. And loss of accuracy is also a marker for OAM accuracy. So this is how we assess the pedicle accuracy. This is grade 1 breach, you can see. This is grade 2 when less than 2 mm is, this is normal. This is grade 2 breach. This is more than 2 mm. This is more than 4. This is functional breach. So neurological structures are affected when there is more than 4 mm of breach. So we call it a critical breach. So breach more than 4 mm. So facet violation, if superior facet is violated, greater mechanical stress and adjacent segment disease. Segmental kyphosis also, if we can't readjust the kyphosis to less than 11 degree, then study suggests that it will lead to loss of compensation and there will be a progression of kyphosis and loss of sagittal balance. So radiation exposure, since OAM use a cone-based CT radiation, so radiation is more to the patient compared to a C-arm, but the radiation to the staff is less than 10 times compared to a fluoroscopy if MIS screw was used. And if more than 6 screws were inserted in OAM, then this radiation criteria is non-significant. So this is our results. Demography, 23 fractures were highly unstable and 64 were unstable. So overall breach rate was 8%. And the significant that I mentioned in earlier slides, the significant breaches were 5. That is less than 2% of the whole study. And they were all revised intraoperatively without any neurological deficit post-op. So this is the breach pattern. So in this we can see the critical breaches that were more in the unstable fracture variants. This is the unstable fracture, the light blue line. So more than 80% of the critical breaches were in the unstable fracture, highly unstable fractures. Facet violation was quite acceptable, less than 1% of all. And radiation and loss of accuracy, we experienced 5 cases of loss of accuracy, and the mean radiation is 9 millisieverts, which is well in the acceptable range. Permissible is 50. And mean kyphosis correction we could achieve was almost 4.5 degrees. The green line is pre-op and the post-op. So the conclusion is, we conclude that micromotion and macromotion does affect the accuracy of OAM, which may lead to higher incidence of pedicle breaches. And but so this is a case. This is a D12 burst fracture with B2 component. We did it percutaneously. So this is our reference frame. This is MIS screws, and this is the final incision. This was a morbid patient, 70-year-old, so we did a MIS fixation. This was the kyphosis correction from 19 degree to 10 degree. So take-home message is, one must avoid any correction maneuver before inserting all the pedicle screws. Accuracy should be checked before inserting every pedicle screw. So we should always take more care in highly unstable fractures, and navigation data must be verified with anatomical landmarks. Thanks. And percutaneous fixation should be avoided in unstable fractures. Thank you so much for your time.